This is the last section on pediatric pharmacology, and this is in relation to intravenous therapy. IV therapy is commonly used in the inpatient area, in the emergency room, urgent care, outpatient clinics, as well as the home care setting. When we administer medications, we can give either a continuous infusion, intermittent piggyback, as well as IV push. And any rumor mills that you've heard that you cannot give IV push medications to children, that is not true. It's very specific to certain hospitals, but none that we go to. So as you know, IV therapy can be given to get a more rapid drug level, to give nutrition, to correct fluid and electrolyte imbalances when a child is sick with gastroenteritis. We also give IV narcotics and sedation for procedures, as well as administering blood products, very similar to adults. So when you think about the IV sites, we want to use their non-dominant extremity as much as possible. The most common areas that we're going to see used is the hand, the wrist, and the antecubital areas, similar to adults. However, in infants, we may also use their feet or their scalp. And it's very odd for you to see an infant who has an IV that's in the scalp for the first time. We use angiocaths and a 22 or a 24 gauge. And remember, the smaller the gauge, or the higher the gauge, the smaller it is. And they are very flexible. So we want to choose the smallest catheter that can safely infuse the medication, blood product, etc. Make sure you have everything set up and ready, because we want to get in there, get that IV started, and be done, not going in and out of a room. These kids are scared to death. We can give topical anesthetics prior to insertion, so they can come as the EMLA, as we would for an IM, or we have the sprays it makes a noise and it's very cold, but it is very effective. Explain the procedure to the patient and the parents prior to and during the procedure. And then you go through standard procedure. You're not going to be starting IVs on kids. If you're lucky and you're at chalk, you might start an IV on a kid in the ER or in the outpatient clinic, but usually not. Explain the use of the pumps and let them know that when the pump is alarming, to put the call light on so that we can come in and adjust it. Sometimes parents just feel so helpless because the alarm is beeping, they don't know what to do, and that sound drives them crazy, as well as the child. We want to stabilize the extremity with arm boards. We no longer pin the arm board to the bed so that the kid can't move it. We just cover it up and use an arm board. So we have a variety of venous access devices. So we have the peripheral IVs, which is common, and sometimes these are going to be just in as a saline lock. Very rarely are we using a heparin lock. It's going to be institution dependent. When we use an intermittent infusion site, it's because all we need to do is give the medication. The child doesn't need any additional fluid. Most institutions are going to have a routine for flushing, which is once a shift at the beginning. And this is going to do two things. You're making sure that you have a line, and, well, essentially that's what you're doing. And then remember that when we have an intermittent IV, we want to use saline to make sure your line is open. We administer the med, and then we administer more saline afterwards. And because we're not hanging IV bags, you're just going to use that 10 ml syringe with saline in it as your pre and post saline infusion. Usually 1/2 to 1 ml is ample as a flush volume. And in some institutions, the tubing is only like 0.3 mLs. So that's all that you have to use. For infants that are less than 8 weeks of age, we want to use preservative-free saline or heparin. Always check your IV site at least once an hour when you have fluids flowing through them continuously. And then if it's locked, you need to check it every 2 hours, at least the site. You're not flushing it, you're just checking the site. You are going to encounter a variety of central lines that we use in pediatrics. We used to use a lot of peripheral lines, and these kids would knock them out, and it would be 9 or 10 sticks to get another one in. So we are using PICC lines far more frequently than we ever have in the past. And it causes a lot of reduction of the anxiety for this child. So the top left picture is a PICC line, and they can have a single lumen, double lumen, or triple lumen. And then we have the variety of lines that are in the Hickman, which is on the top right, and you can see this is a double lumen. And then we have double lumen Broviox that are on the far right bottom. And you can see that in the middle is the rubber stopper. We do need to use a specific needle for it. And then on the bottom left is a portacath. So when you're using a central line, you always need to check compatibility of the medications and the solutions, especially when we have TPN and lipids infusing through them. And sometimes you're going to have to stop them, administer saline, then the med, give saline, and then restart the TPN or lipids. Assess the site every shift as well as prior to drug administration. These kids are mobile. They can knock that needle out, and then next thing you know, you're administering drug into the subcutaneous tissue. On these access ports, you need to use a non-coring needle, and the Huber needle is an example. The dressing changes are going to be per protocol for the institution, but usually once a week or whenever soiled. We do use chlorhexidine prep prior to insertion to clean them and for dressing changes, and then we apply the biopatch similar to what we do with adults. We're going to follow the flushing protocol that your facility requires. And the proper amount, just keep in mind that for a neonate and an infant, it's going to be a lot less than what you would be doing for a healthy 17-year-old. 10 cc's of saline per lumen, followed by 3 to 5 mLs of heparin, sort of the standard. And the dosage is usually for these central lines 100 units of heparin per ml. But once again, you're going to follow the policy of the hospital. PICC lines, generally, we're going to flush at least once a day, Hickman's weekly, and ports monthly. And these are things you're going to remember for when you are actually licensed. As a student, you're not going to be accessing the ports or the Hickmans. PICC lines, you will. Is the end of this section and the entire lecture on pharmacology.